Hi, welcome. Thank you so much for joining. I appreciate you. We're excited to get started tonight. We'll give it about 30 more seconds, let a few more folks come in, and then we will kick it off. Hi, it's very nice to see you. Thank you for coming. Appreciate you. Hope you're enjoying this super dark, gloomy day, gloomy night. It gets dark so early now. Thank you for coming. Appreciate it. Hi, welcome. It's good to see you. Thank you for joining. We'll get started in about 10 seconds. Thank you, everyone, for attending. Hi, nice to see you. Thank you for being here. All right, let's get started. Good evening, everyone, and welcome to A Lever, Empowering Parents to End Waitlists, brought to you by NAMI Cook County North Suburban and Bob Anthony, a chairperson of the Mental Health Initiative's Rotary Actions Group. I am Bree Hoekstra, the program director at NAMI Cook County North Suburban. NAMI, or the National Alliance on Mental Illness, is the nation's largest grassroots mental health organization, providing public awareness, no-cost support, and education programs online and in person so that people and families affected by mental health conditions can build better lives. We are a lifeline to individuals and families who do not know what to expect on their difficult life journey. We offer classes and support groups and do a lot of advocacy for mental health. Our programs are free of charge and open to those in our community service areas, but we don't turn anyone away who is in need. Our topic tonight will provide further education on the Guided Self-Management Toolkit, a resource for parents and/or guardians to actively partner in immediate treatment for all mild and moderate cases of ADHD, anxiety, depression, and disruptive behavior disorder. According to the CDC, ADHD, anxiety problems, behavior problems, and depression are the most commonly diagnosed mental health disorders in children. The article goes on to say that early diagnosis and appropriate services for children and their families can make a difference in the lives of children with mental disorders. Therapy and therapists are essential for supporting our mental health. According to Psych Central, there are many good reasons for therapy, such as having a better understanding of your mental health, developing wellness goals, identifying triggers that lead to symptoms or unhealthy behaviors, improving interpersonal relationships, coping with stress, creating a personal plan for mental health crisis, making sense of past trauma, overcoming fears, and creating routine and stability. It is clear that therapy is a wonderful treatment option for young people. However, sometimes individuals can be put on waiting lists. If this happens, how can families continue to support their child? During tonight's webinar, you will learn how the prescribed guided self-management toolkit can help parents and/or guardians actively partner in immediate treatment. We will leave plenty of time for Q&A at the end. If you'd like to type your questions in the chat box during our conversation, please do. Tonight's guest speaker, Bob Anthony, is the founder and executive director of Adolescent Wellness, a 501c3 nonprofit to promote practical resources to prevent mood disorders and prompt early treatment. Bob moved to Naples from Boston in 2019 with his wife, Nancy. They have 2 sons and 2 grandchildren. He received his MBA from DeVry University Keller Graduate School of Management. For Rotary, Bob chairs the Mental Health Initiative's Rotary Action Group, which facilitates programs to break stigma, raise awareness, and increase capacity for earlier treatment and prevention. We are so thrilled to have him here tonight to further educate us on this ever-important topic. I am honored to welcome our guest speaker tonight, Bob Anthony. Thank you, Bob.
Well, thank you, Bree. That was delightful. I am really pleased to be talking with everyone tonight because I grew up pretty close to where you're standing. I had lived in Hinsdale for my formative years, and my wife Nancy is a graduate of Northwestern University, not too far from where you are. You mentioned DeVry and Keller; those are downtown Chicago, so I have lots of fond memories. speaking to you right now from Naples, Florida. And I was able to learn about NAMI through the NAMI affiliate, Collier County, where I am living. So we've done this program locally. And one of my hopes is that in addition to sparking some ideas, we'll spark some actions to see your counties adopt the same programming. It's not a cost thing, it's a priority thing. It's having a few people decide, yes, we'll do this now as opposed to 5 years from now. So I have some slides. May I show those?
Absolutely. I'm going to hop off and I'll see you soon. Bye, everyone.
So hopefully that comes through clearly, Bree. Do you see that?
You got it.
Okay. So if we can, oh, that's interesting.
Perfect. We can
Thank
see
you.
that.
Okay, now we're rolling. So this is really a nickname, a lever. It's been proven to empower parents and to end waitlist for the child psychiatrist. And we call it the lever because the official name is much longer. It's from Boston Children's Hospital. New this year, it was just released nationally. And the formal title is Building Bridges of Understanding. So you'll see those logos and some of those documents as we walk through the presentation. But I just call it a lever because we're leveraging the existing workforce to fill the gap between what's needed and what's available through child psychiatrists. The reason it's so important, you already know, but the statistics nationally are 10-year delay between first onset of these pretty common symptoms of childhood and teenage years and the first treatment. And that's for the lucky half of the youth population. The other half never get the treatment. So to be clear, there are not just common disorders, but different levels of severity. So we are talking about anxiety, depression, ADHD, disruptive behavior disorder, and all of these can be mild, moderate, or severe. The program that I'm talking with you about tonight is to directly manage the mild and moderate cases. We still depend on a child and adolescent psychiatrist to be involved if these are either severe cases or complex. A lot of comorbid things or a lot of general health issues that interfere with medication. But we're talking about a large segment. We're talking about 7.5 million youth who have these mild and moderate symptoms. The severe cases are just 25% of the total. And this is a solution for that 7.5 million. So I'm thrilled you're here because you can do this. This is empowering you to bridge the gap to early treatment. And the reason that gap exists is there's just 10,000 child and adolescent psychiatrists available. These are the ones who write the scripts. You can talk to a therapist, but you can't get a prescription. And sometimes you want both. Ideally, you can have both. At least you want a prescription if you can't get either. The prescription is a quick way to go. But those 10,000 child psychiatrists are being asked to see literally 10 million patients. It never happens, and that explains the 10-year average wait and the fact that half the population never sees the treatment. So we're talking about empowering the parents through the existing workforce of pediatric primary care providers. I'm talking about pediatricians, yes, but I'm also talking about nurse practitioners, physician's assistants, family doctors, anyone who's a first line of contact for families' general health. And this is huge. This is a breakthrough because they're terribly smart people, but they left medical school to go to work. before getting into the additional years of training and specialties and subspecialties like psychiatry and then child psychiatry. We talked about 10,000 child psychiatrists we can't get into. Well, we can get into 60,000 pediatricians or 120,000 family physicians and many more physicians' assistants and nurse practitioners. This is a solution that all of them can adopt. So as a result of this program, providers can access the self-paced training. So it's convenient. There's just like Khan Academy, the short video clip, short test, and then repeat. That's the way this program is set up for the providers. It's a series of 16 20-minute sessions. So literally during a coffee break, they can knock off one of the sessions. The elapsed time is just 5 hours. So it's not a heavy lift, and it delivers the mandatory continuing medical education credits, the CME. These are Category 1 AMA recognized credits for a provider anywhere in the country. In addition, there's a network of phone consults available for the family doctor, for the pediatrician, for the nurse practitioner to talk about a case, get a case consult if people are uncertain whether this is a moderate case or whether it's falling over into that severe or complex diagnosis. You can see the phone number on the bottom. That's the case consult number, and it's free. It's free to the providers who make the phone call. Most importantly, the thing that's unique that is part of this Boston Children's program that did not exist with other training approaches are these toolkits. And so the folks who graduate the 5-hour course can access the library of guided self-management toolkits to prescribe directly to the patient, the child or the teen, and the parent. So for the first time, the parent knows exactly what the treatment's supposed to be and can participate as an equal partner on day one, same day there may be a diagnosis. So when the youth screens positive, they prescribe the relevant chapter. And within that book, you see the cover there, there's a section in anxiety for the patient, age 6 to 12. There's a totally different toolkit if it's a teen, same topic. And if it's a teen, there's a third toolkit for the parent who has to deal with the teen and work through the exercises. And you repeat that for depression. There's 3 there. You repeat that for the ADHD. Disruptive behavior disorder is really focused on the younger set. So there's not a separate teen and adult set. It's geared towards the child working with the parent. So there's a total of 10 of these toolkits. We introduced this, I say we, I'm active with the Rotary Club in Naples. And our healthcare system is really a rural healthcare system. If we want a psychiatric pediatric bed, we have to cross state to Miami or head 3 hours north to Tampa, assuming there's a bed there. And if there were a bed there, we'd have to get a hotel. It's not convenient to do day trips back and forth. So the fact that we were able to introduce this to the pediatric primary care providers right here in sleepy Naples was huge. They did pre-post surveys. These are doctors. These are very smart people. Just a result of this 5-hour program, they doubled their knowledge of the symptoms and the treatment. They doubled their confidence at the same time. So literally, these are statistics from our area. They earlier were 41% confident about managing these types of cases, which meant they really didn't get involved if they could possibly avoid it. After the 5-hour training, 99% confidence level. And as a result of both that knowledge and confidence, their intention to start treating these things directly in the pediatric office jumped to 94%. So that is how we break the dependence on the child psychiatrist. This is a video, and speaking itself, it goes 5 minutes.
Which patients do pediatricians say they worry about the most? It's their patients with behavioral health problems who are really struggling to function but can't get access to care. What can be done about this? Studies have shown that 3/4 of children and adolescents with behavioral health struggles have problems that are mild to moderate in severity. If pediatricians can acquire the knowledge and skills necessary to safely and effectively manage these patients, then scarce specialists can be reserved for the management of the 1/4 of patients with more severe problems. Pediatricians now have access to behavioral health knowledge and skills through a new web-based self-paced video course entitled Behavioral Health Education for Pediatric Primary Care. This 5-hour course, targeting the behavioral health problems most commonly encountered in pediatric practices, focuses on the identification, assessment, and treatment of mild to moderate presentations of anxiety, depression, and ADHD. This course can enable pediatricians to acquire the key mental health competencies developed by the American Academy of Pediatrics. 5 AMA Category 1 credits are awarded by Boston Children's Hospital upon completion of the course. This course was developed by experts in child and adolescent psychiatry at Boston Children's Hospital, who have national reputations in the area of behavioral health consultations to pediatricians. Also teaching in the course are experts in clinical psychology, who lead psychology training programs at Boston Children's. The course provides a comprehensive overview of the identification, assessment, and psychological and psychopharmacological management of anxiety, depression, and ADHD in the primary care setting. The course introduces the stepped care model, a straightforward 4-step model of care for anxiety, depression, and ADHD in the pediatric setting, entailing screening, assessment, primary care treatment, and referral for specialty care treatment. Detailed information about universal behavioral health screening for children and adolescents is provided. If the screen is negative but suggestive of developing behavioral health problems, information is provided about the use of a guided self-management toolkit for patients and families, designed to help prevent the escalation of developing problems into full-blown disorders. If the screen is positive for behavioral health problems, the course introduces a focused behavioral health assessment. Detailed information is provided about the use of problem-specific symptom rating scales to assess symptom severity, and about the implementation of a focused clinical interview to assess symptom history, complexity, distress or impairment, and safety. The information derived from the focused assessment guides triage of the case to either primary care or specialty behavioral health care. If the case is appropriate for primary care, the course introduces primary care management. Information is provided about evidence-based psychotherapy to guide brief self-management interventions by pediatricians. Detailed information is provided about pediatrician prescribing of evidence-based first-line medications for these disorders as appropriate. Information is also provided about appropriate home and school supports. Upon completion of the course, participants can download resources to support their behavioral health care, including a clinical manual for pediatric practitioners and a guided self-management toolkit for families. If you are interested in the outcomes of this course, here are the references to articles published in leading pediatric journals. To date, hundreds of pediatricians from Massachusetts, Connecticut, California, Florida, and Texas who have taken this course report that they greatly enhance their behavioral health knowledge and skills, enabling them to confidently expand their scope of practice to the emotional and behavioral needs of their patients. In so doing, pediatricians can play a key role in closing the gap between the millions of youths needing safe and effective behavioral health services and those receiving them. The development of this course was made possible by funding from Boston Children's Hospital, the Sidney A. Swensrud Foundation, and the Nancy Adams and Scott Schoen family. Please visit us at dme.childrenshospital.org/buildingbridges to register or learn more.
So why must you act to make this happen. Well, the reality is this works. It's wonderful. It's proven. There's lots of peer-reviewed literature confirming that. I've got personal experience. I guarantee it works. But new interventions languish for about 15 years before they're widely incorporated into usual medical care. That's just the way it is. Everyone's busy. They get around to it when they get around to it. Someone here may adopt it, someone there may adopt it. Unless a parent says, dear doctor, have you completed this course? And may I have a copy of the guided self-management toolkit for my child and for myself? There's no particular reason for them to do it this year or next year or the year after. They've got thousands of opportunities for continuing medical education. Only you can make this their priority for this month. So it's real, and you have a real role to play in making this happen sooner as opposed to later. So that is the message that I wanted to deliver to you. If you're wondering whether the pediatricians like the extra work, they care about the patient. They hate to refer the patient out because they know that doesn't mean that they're going to see someone anytime soon. And they still have the problem, both the patient and the doctor. And this is the type of illness that doesn't improve by ignoring it. If it can be addressed when it's mild, it can be kept oftentimes from going moderate and from moderate to severe. So they want to do this. The head of pediatrics for Healthcare Network, which is the largest here in Collier County, wrote, there's been greater engagement with our own behavioral health colleagues to co-manage patients while using these self-management techniques that they learned, as well as our writing prescriptions that they didn't write before. The material was priceless, as we refer to it as needed, and the information for our patients has been easy to implement. I hope more practitioners continue to join us on a journey to make mental health easily accessible to our most vulnerable population, our children and adolescent patients. So that's the end of the presentation of ending waitlist for a child psychiatrist. The QR code goes right to the registration at Boston Children's Hospital for this 5-hour course. It is $250, which is an average price for 5 continuing medical education credits. And it's web-based. They don't have to go off and sit at a conference. They can do it at home or when they get a break in the office. I'm here for questions, and Bree, I'll let you take it from here.
Hi, everyone. Thank you so much, Bob, for providing us with that ever important information. And I know our guests may have some questions for you. So let's get that conversation going. If you have any questions, please feel free to drop them in the chat. I did see some people were asking questions throughout your presentation. So we have a couple here already for you, Bob. The first one, I think it refers to one of your first slides. It says, why is there a 10-year delay of onset and symptoms? So interesting.
Yeah, so to be clear, it is on average 10 years between first symptom and first treatment. And the reason is, lack of recognition, both by the patient and by those around the patient, including the family and often the provider. And then once it's identified as, we have a problem here, trying to get in to see a psychiatrist is no mean feat. So literally it can translate it into 10 years. I can give personal experience. I was diagnosed with depression at age 50. And having now learned a little bit more about it, symptoms were obvious to me today back in grade school. So that's more than 10, I'm way more than the case example average. It took me 40 years.
Yeah. I can see that 100%. Thank you for sharing. Next question says, how easy can one follow this guide without the traditional educational background or a license?
It is written for the child, and it is written for the teen, and it is written for the parents. So that's the reason there are three different toolkits for the same melody. It is intended for the child to exercise and track their progress. It is intended for the teen to do on their own. And it is intended for the parent to be able to read it, maybe give some additional coaching and try to facilitate compliance and do the reporting back to the pediatrician's office.
That leads me.
Does that answer the question?
Let's see. I believe so, yes. And I'm just a question that I have to follow up. How long does it typically take for a parent to engage in this type of curriculum, let's say on a daily basis? How long is the practice?
Well, it's a toolkit of a dozen exercises, for example. If you think about depression, a lot of exercises we're familiar with, like, take a breath or progressive muscle relaxation, calm you enough to maybe recognize the source of your problem, but you still have the problem. So in addition to the types of centering exercises, there for an example, there's a creative problem solving activity where you identify the problem, you reframe it, writing it several different ways, selecting what's the real problem that's under your control, and then brainstorming, developing a number of ideas that could be useful in resolving the problem, and making a choice, selecting one. And then most important in this process is actually putting a plan together, beginning today, of who needs to do something. And it always has to include you, but you can ask for help, a date that task gets completed. And at the end of, it depends on the age, but for a young person, maybe at the end of the week, you should have resolution of whether that was a solution or you have a new problem identified, and you keep working from there. So that particular activity that I just described, I call it PIP, problems, ideas, plans, can be as quick as 10 minutes, 15 minutes, and then reused. The same thing could be reused as you reframe the problem and perhaps identify different problems going forward. So it's just a series of thinking exercises that develop your resiliency.
Wonderful. It sounds like a great opportunity for a child and parent to just bond on a daily basis, spend some time together learning about mental health. That's wonderful. Thank you for that. Next one says, how do you recommend we approach our family doctor to take the training? What is the best approach?
One is simply to ask the question, have they been able to complete the course from Boston Children's Hospital called Building Bridges of Understanding? Because you as the patient and interest of your child are very much interested in getting a copy of the, it's called Guided Self-Management Toolkit. So that's a beginning question. If the answer is no, it's just a normal conversation. Is that something you could please make time for? And I have had those conversations a lot in promoting this. And the most common response is, oh, we've already done something very similar to that. I took REACH training, or I took this other training. And that's probably a true statement. It's not, this type of solution has been talked about by the medical profession for over a decade. And there have been a series of seminars trying to lift the workforce to take on behavioral health care. It has failed because there's no time for the pediatric provider to fill in the role of a therapist. They can write a script, but you're not going to write a script for a very mild case, or you shouldn't. And even for a moderate case, these things tend to go a lot better with both talk therapy, if you will, and the script. So the pediatricians are afraid of the black hole of lost time if they pretend to be the psychiatrist. What is unique about this program is that the parent becomes the talk therapist. Hmm. And suddenly you've got a partner in this, and they're both, making the solution happen. It's not more time; it's more effective time.
So do you recommend, just a question that I have, you still recommend though, however, that children do see therapists, maybe after the waiting list period, even while they're, so it's more like a supplemental material,
sure. Yeah.
Replacement. Oh,
yeah,
wonderful.
I mean, and in the same vein, if you can get into a child psychiatrist, see the child psychiatrist. We hate to see them homeless,
Right.
But
right.
I sincerely would love to see is that the child psychiatrist never sees another mild or moderate patient, but is focused on actually getting through the backlog of severe and complex cases.
Right. Wonderful. Let's see. Does anybody else have any questions? Give a couple. Okay. Looks like we are out of questions. Would you like to add anything else, Bob, before we say our goodbyes?
Only that this is practical. It works. I have been able to have a film crew interview a family that's participated with the toolkits. They'll be out at the end of the month. And, the barriers are just a priority. Again, it's not a major funding thing. It's not a major time thing. It just make this a priority over the other things on the list. And that's true for the parent, and it's true for the provider.
You did say that you had personal experience. Would you mind sharing a little bit about that?
Yeah, so I had personal experience in two ways. One with the element of depression, but more recently with actually introducing this to doctors in the Naples and Collier County area. They weren't aware of it. And the odds are quite high that the doctors in Cook County and the northwest suburbs of Chicago are not aware of it. So it's simply making them aware that it is convenient training and that it is bundled with a set of tools that didn't exist before. That was new information. A third piece, I had mentioned briefly that phone consult for the provider, where the pediatrician can pick up the phone, talk to a child psychiatrist, confirm what they're thinking. That was in place and has been in place in Florida for years. And in fact, it's in place in every state for a couple of years. Most, or at least the pediatricians in Collier County were not aware of it. And when we called the number, it wasn't being answered. So the fact of us pushing and saying, how come no one's following up on these phone calls, got the phone answered. And so now that's a vibrant piece of the support network for the professionals. And now also the professionals are not just the pediatricians who were part of this pilot program that we helped them implement. They're now within their own network, going to their family doctors, going to their nurse practitioners, going to their physician's assistants. So they are, now spreading the word. But none of this would have happened if me, an old parent of grandchildren now, wasn't asking the question. So it really is just starting the conversation with the provider and making sure it moves on to the next level. The personal experience was just, at age 50, I was making some poor business decisions and making life hard for my family. And finally got someone to say, go see someone. And it took a couple tries to find the right provider, but I did some prescriptions for a year and talk therapy for a couple of years probably. and made all the difference, you know. So coming out of that dark area, I was still angry about the fact that it took so long to see this, and that's a driver for me. I'd love other families and other people not to have to wait 40 years to make things a bit easier.
Well, it's wonderful. Thank you so much for sharing. Another one that I thought of too as well. You did say that pediatricians are using this in some areas. So have you gotten any feedback from these pediatricians to say how well it's working and, just their comfort level with prescribing this?
Yeah, so I showed the one quote who's the head of pediatrics for the network here in Collier County, saying they're very pleased about it. Separately, in conversations with the same leader, he said, we want to help our patients and we weren't able to help them. Now we can help them. So they're very pleased about that. The other thing that we're seeing is that it actually saves time, because these things aren't just isolated, oh, this child's anxious. I mean, it leads into a whole set of other ailments that can take time in the pediatrician's office. So this is a net time saver if you're ahead of the problem.
Yeah, wonderful. Well, thank you so much for sharing. It sounds like a wonderful tool. I think one of the best parts is the bonding that you will probably receive with your child through doing something like this. Well, thank you. Thank you so much, Bob. Is there any final thoughts?
Thank you, Bree.
Of course, anytime. We're happy to have you. Okay. Well, if we don't have any more questions, I know it's a little early, but that's okay. It's dark and we're sleepy. So if you did enjoy tonight's program, you can find more information about upcoming programs and events at www.namiccns.org. Our next program will be held on January 17th from 7 o'clock to 8:30. So please mark it in your calendars. We are going to have a guest speaker. Her name is Renee Dominguez, and she is going to kick off a series of webinars that are focused on specific mental health conditions. So Renee Dominguez is going to teach us a little bit more about anxiety disorder. I'm very excited to hear that one. So once you log off, you will see a short survey that will both allow us to better understand your comfort level with tonight's presentation and the topic, as well as provide us with information that we need to continue providing free mental health services to our community service members. We appreciate your presence tonight, and we look forward to seeing you at another NAMI CCNS webinar. Please take care of yourself and each other, and happy holidays, everyone. See you next year. Bye. Thank you, Bob.